আমরা লাইভে আছি, ডক্টর শোয়েব মোমেন, আমরা লাইভে।
Okay, okay. Dear participants, Assalamu alaikum. Good evening. It's a pleasure that Bangladesh Rheumatology Society has organized this webinar on arthritis associated with inflammatory bowel diseases. Although it's not that common, especially in our country, however, it's important to remain vigilant. Otherwise, we may miss the diagnosis. As usual, today we have two young rheumatologists to speak. And many of you know that we try to encourage our young rheumatologists in this program. Today we have two invited guests. One is from Sri Lanka, Dr. Kalum Deshapriya, a very popular consultant rheumatologist of Sri Lanka. And Dr. Kalum was also with us in our another webinar on systemic sclerosis, and it was held on 2nd July 2021. And despite ongoing turmoil in Sri Lanka, he took the trouble to spend time with us. Welcome, Dr. Kalum Deshapriya. And we have with us a famous gastroenterologist of our country, Professor H.M. Roshan. He was the professor of gastroenterology, Sri Sarvadi Medical College and Hospital. Welcome, Professor Roshan. Now I would like to request our moderator, Dr. Shoaib Momin Majumdar, to start the scientific session. Dr. Shoaib Majumdar, please.
Thank you, Professor Minhajur Rahim Chaudhary sir, for giving me the opportunity to moderate this August session. So as Professor Minhaj sir has already told that we have two young vibrant speakers, Dr. Taskia Haq and Dr. Mohammad Nojibur Rahman. May I like to introduce these two speakers. Dr. Taskia Haq is working here. She has passed her MD from Bangabandhu Sheikh Mujib Medical University and working as a rheumatology specialist in Mugda Medical College Hospital. And Dr. Mohammad Nojibur Rahman, he passed his MD from Bangabandhu Sheikh Mujib Medical University and working as a medicine consultant in Upajala Health Complex, Chandonaish, Chittagong. The first speaker will be Dr. Taskia Haq. She will talk on the clinical manifestations and diagnosis of inflammatory bowel disease associated arthritis. I would like to tell that if you have any questions at any part of their presentation, you are cordially invited to put your questions in the chat box. So you can message or you can write in the chat box. We'll try to answer all the issues after the completion of the presentations. May I request the first speaker, Dr. Taskia Haq, to present her talk. Dr. Taskia Haq, please.
Honorable Chairperson, respected panelists from home and abroad, and all the audience. Assalamu alaikum. Welcome you all to today's webinar on arthritis associated with inflammatory bowel disease. I'm starting my presentation on diagnosis of inflammatory bowel disease associated arthritis. I have divided my presentation into history of the IBD arthritis, epidemiological aspect, pathogenesis, clinical manifestations, important investigations, monitoring of disease activities, and some differential diagnosis of the clinical condition. Inflammation of the axial and or peripheral joints is one of the most frequent extraintestinal manifestations that complicate the clinical course and therapeutic approach in inflammatory bowel disease. IBD-associated arthritis is a subgroup of spondyloarthritis, that lack of recognition in rheumatology clinical and research circles for initial around 100 years. Although it is clinically distinguishable from rheumatoid arthritis and ankylosing spondylitis, the middle of the last century only made the final separations of this clinical entity. Let's have a recapitulation on the ASA's classification of spondyloarthritis. In this picture, we can see that spondyloarthritis can be split into axial, peripheral, and extraarticular involvement. All of these can be converted into ankylosing spondylitis in their disease course. On the other hand, there are some interrelated disease conditions like psoriatic arthritis, reactive arthritis, arthritis associated with IBD, undifferentiated spondyloarthritis, and juvenile SPA, which also can become present as ankylosing spondylitis in their natural history. If you want to diagnose SPA according to ASA's criteria, I just want to highlight in this picture that there are two arms. One arm has sacroiliitis on imaging and another HLA-B27. If we have imaging positivity, then one SPA feature is sufficient for making the diagnosis. But if we have HLA-B27 positivity, two SPA features are needed. And among the SPA features, Crohn's disease or ulcerative colitis is a important SPA features. Let's talk something regarding the history of IBD arthritis. How this terminology actually established. The initial description of a relationship between arthritis and inflammatory bowel disease goes back to 1895, around more than 100 years ago, when William H. White wrote in his article that among 23 cases of ulcerative colitis, 2 patients had urate of soda in their joints when he found arthritis in ulcerative colitis cohort in his study. Then, in 1929, peripheral arthritis was first described in IBD patient. And peripheral arthritis had flare associated with exacerbation of colitis episode. Then, for several decades, patients with this condition were often classified as having rheumatoid arthritis. At the end of the 1950s, sacroiliitis was described in IBD patients. Then, in 1964, IBD-associated arthritis was established as an independent clinical condition. And this is included in the spondyloarthritis group in 1976 only. These are some early epidemiological studies of IBD-associated arthritis cohort, which started from 1960 up to 2008. These are included in this article. I'm not going into detail of those. Now, let's talk about the epidemiological aspect. Arthritis has been estimated in around 6 to 46% of patients with IBD, and spondylitis was described in 1 to 26% of IBD patients. Although these studies has significant heterogeneity among their patient collection. Conversely, among the diagnosed patients with spondyloarthritis, the prevalence of IBD is lower. One large meta-analysis found that IBD occurs approximately 6.8% patients with diagnosed ankylosing spondylitis, which is far less than the occurrence of arthritis in IBD patients. But subclinical gut inflammation has been described in up to 2/3 of patients with spondyloarthritis, which was documented by endoscopic procedure like ileocolonoscopy. And asymptomatic sacroiliitis is frequently discovered on pelvic imaging, which was otherwise performed for assessment of the patient's IBD, but they had no clinical symptom. And 20% of peripheral arthritis patient and 40% of axial disease, 40% patient of axial disease present clinically prior to the diagnosis of IBD. And on one population-based study found that in ankylosing spondylitis patient, the highest risk of developing IBD was within the first year of diagnosis of spondyloarthritis. Arthritis may occur more frequently in Crohn's disease than ulcerative colitis, which is reported in some studies. And the risk factor for arthritis are active disease or family history of IBD. Female may be at greater risk for peripheral arthritis, where men tend to have more frequent axial involvement. And arthritis is more likely in patients, those who have large bowel disease than small bowel, and with other extraintestinal features such as erythema nodosum, stomatitis, uveitis, and pyoderma gangrenosum. Male and female patients are affected equally, and these affect children and adults with same risk. Now come to the pathogenesis. Here are some important points regarding pathogenesis. Disruption of the gut barrier, and one interesting finding is that patients with all subset of spondyloarthritis have demonstrated subclinical evidence of gut inflammation. And in IBD and SPA patient, this biosis is found. Shared genetics played a role importantly in this pathogenetic mechanism, and Th17 pathway is an important pathway for IBD arthritis, as like other SPA counterpart. And how the arthritis develop in the setting of IBD. Two major theories has come, but yet they are not fully developed. One theory is gut bacteria, and another is migration of gut lymphocyte directly to the joint. Now, if we look at this picture, it will be more clear. In this picture, on the left-hand side, there is gut, that is here the process of IBD is going on, and on the right-hand side, here is the arthritis counterpart. In gut, at first, this biosis occur, and it is seen that some bacteria like Prevotella, Proteobacteria increase in this subgroup of patients, and then mucosal barrier gets disrupted. In the gut, mucosa is lined by tight epithelial cell with intraepithelial lymphoid cell within them. And beneath the epithelial cell, there is basement membrane, then lamina propria. And in the lamina propria, we can see dendritic cell, macrophage. These immune cells reside in the lamina propria layer. And here are some one or two more important things. One is innate lymphoid cell. Innate lymphoid cell reside in the crypt of liver cone, and this is called the counterpart of T lymphocyte in innate immune system. That is, this is the T lymphocyte of innate immune system. Then, when this mucosal membrane is disrupted, there for the secretion of IL-22, IL-17, and TNF-alpha. Also, Th17 pathway is activated. The same condition also can be seen in the arthritis joint counterpart. More than that, there is another counterpart of tissue adhesion molecule like integrin. Here we can see the integrin molecule alpha 4 beta 7, which is important in gut and which is also found in the joint layer. There are some different hypotheses. One is directly intestinal inflammation causes antigen antibody and immune complex is deposited in the joint. Another is directly antigen itself migrate to the joint. And when this integrin, that is adhesion molecule, was described in the pathogenesis of IBD arthritis, it was established that it helped in the lymphocyte trafficking. That means lymphocyte of the gut system to traffic towards the joint site. Here we can see that IL-23 increase the secretion of IL-22 and IL-17, which has distinct function. IL-22 mainly causes osteoproliferation and inflammation, and IL-17 causes both inflammation and bone loss. Ultimately, the features of the spondyloarthritis is created. Then come to the clinical manifestation. There are peripheral arthritis, spondylitis and sacroiliitis, enthesitis, and in some patients, Sapho syndrome and hypertrophic osteoarthropathy. Peripheral arthritis, I will describe just a slide later. Now, spondylitis and sacroiliitis. Up to 20% of patients with either form of IBD present with spondylitis and sacroiliitis. And the interesting thing is that the course of spinal involvement and spinal disease progression is independent of the IBD course. And they may precede by years the first manifestations of bowel disease. That means spinal involvement may come very much earlier than bowel disease. And also there is an interesting finding that asymptomatic sacroiliitis can be seen in up to 32% of patients with IBD. Enthesitis and dactylitis are less frequent in IBD-associated arthritis than other types of spondyloarthritis. There are some extraintestinal manifestations of IBD and extraarticular manifestations of SPA, commonly seen like uveitis, erythema nodosum, and myoderma gangrenosum. These are some typical clinical pictures of arthritis, enthesitis, dactylitis, and inflammatory back pain. Then come to the peripheral arthritis topic. There is historical classification of peripheral arthritis into type 1 and type 2. Although now rheumatologists often not use this commonly because now we use the ASAS classification that divide the whole scenario into axial and peripheral. Still then, type 1 actually had less than 5 joints involvement, that is postearticular. It was acute and self-limiting attack which resolved within 10 weeks, and it often coincides with relapse of IBD. It is mainly peripheral and it coincides with relapse of IBD. And it is strongly associated with other extraintestinal manifestations of IBD, where in type 2 or polyarticular, 5 or more joints are involved. Commonly, MCP joints are involved. Somehow, RA-like presentation clinically, symptoms usually persist for months to years. And in this type 2 presentation is independent of IBD. It is associated with uveitis only, but not with other extraintestinal manifestation. And both of these are usually non-erosive. So if IBD patients develop erosive arthritis, we need to consider alternative diagnoses such as rheumatoid arthritis or psoriatic arthritis. And there are HLA difference in these two types. Some other musculoskeletal manifestation can be found in IBD, that is non-specific arthralgia. Some are as complications of IBD and its treatment like septic arthritis, osteonecrosis. When an IBD patient comes with mono or oligoarthritis, we need to exclude septic arthritis. Diffuse pain is common in IBD arthritis like other SPA count and RA patients, those which may be myofascial pain syndrome or fibromyalgia. These are a common list of extraintestinal manifestation of inflammatory bowel disease, which involves mucocutaneous, ocular, hepatopancreatobiliary, thromboembolic, pulmonary, renal, neurologic, and hematologic system. How we can diagnose the IBD-associated arthritis? Actually, there are no laboratory tests which confirm the diagnosis. The peripheral blood film, ESR, CRP usually reflect the activity of intestinal disease more than that of arthritis or spondylitis. Sometimes, and spondyloarthritis patient, when they present with unexplained iron deficiency anemia, on the investigation of that patient, IBD is diagnosed. HLA-B27 is an important in regarding the pathogenesis of whole spondyloarthritis, but it is its frequency in IBD arthritis is less than idiopathic arthritis. Idiopathic ankylosing spondylitis. In idiopathic ankylosing spondylitis, HLA-B27 has 90% prevalence, but in IBD-associated axial arthritis, it is 50 to 75%. In contrast, isolated sacroiliitis does not seem to be related to HLA-B27. And the most important thing is that HLA typing does not aid in the diagnosis of IBD-associated arthritis, but it may be that HLA-B27 individuals with IBD are at increased risk of developing axial disease. When a patient comes with mono or oligoarthritis, we do synovial fluid aspiration to exclude the other differentials also. But if it is only IBD arthritis, synovial fluid have typically 5,000 to 12,000 WBC per microliter, predominantly neutrophil. And if we do synovial membrane biopsy, there is non-specific findings. Imaging. Imaging is generally not needed for diagnosis of peripheral arthritis. In contrast, axial arthritis may require imaging for diagnosis. In patients with axial disease, radiographs of spine and pelvis show typical findings of ankylosing spondylitis and sacroiliitis like any other SPA patients. And plain film radiograph of peripheral joints in peripheral arthritis may demonstrate only findings of arthritis without significant erosion or destruction. But radiographs frequently have abnormal findings even in asymptomatic patients with IBD. We have to remember that. These are two pictures of imaging. On the left-hand side, this is the pelvic imaging. Here, SI joint, here is grade 3 sacroiliitis is seen, erosion, and this is the sclerosis. This spinal X-ray, this is the early X-ray of early ankylosing spondylitis. Only shiny anterior border is seen, but in later state, there is bridging syndesmophyte and facet joint malunion. MRI may be the best technique for detecting active inflammation in the spine and sacroiliac joint. And here we can see the bone marrow edema in MRI view of sacroiliac joint. But we have to be cautious regarding advising MRI because asymptomatic patient may also have these findings. So we will advise for MRI if clinical suspicion is strong. There are some methods of assessing and monitoring disease activity like any other rheumatological disease, like ankylosing spondylitis disease activity score, ASDAS, Bath ankylosing spondylitis disease activity index, BASDAI, ASAS health index, routine assessment of patient index data. And here are some markers for assessment of the used for assessment of the IBD, which also help in the assessment and monitoring of IBD associated arthritis. One common inflammatory biomarker, calprotectin. Then these are some novel biomarkers which are still under research, like sclerostin and beta-2 microglobulin. Sclerostin is found lower in case of IBD arthritis, and beta-2 microglobulin, which is a part of MHC1 molecule, is increased in case is found to be increased in case of IBD arthritis. But we have to remember that beta-2 microglobulin is a non-specific acute phase response reactant also. When we deal with IBD arthritis, suspected IBD arthritis patient, we have to keep in mind some differential diagnoses. These are infectious arthritis, that is septic arthritis, erythema nodosum, when the erythema nodosum overlies any joint area, osteonecrosis. In these cases, pain is more marked than tenderness. Reactive arthritis, here the intestinal abnormality and arthritis presentation had a time limit gap. Whipple's disease, Behçet syndrome, here is genital ulcer, eye involvement, celiac disease, gluten sensitive, common parasitic infestation, pseudomembranous colitis after use of antibiotic, or after intestinal bypass surgery, arthritis may also occur. In conclusion, we may say that inflammatory bowel disease associated arthritis is a member of the spondyloarthritis family of disorders. Several hypotheses have been formed to explain how gut inflammation may be linked to joint inflammation. IBD associated arthritis has similar clinical manifestations to other spondyloarthritis family disorders. But to date, relatively little is known about IBD associated arthritis specifically, and still it remains an understudied disease entity. These are the references I used. Thank you all for patient hearing. Thank you.
Thank you, Dr. Saskia Hawk, for his nice and elaborate presentation. Now we'll proceed towards our second presentation. Already we have got some of the questions towards the first presentation. I would request the audience, if you have any questions for the second presentation, please put in the chat box. So I would like to request our second presenter, Dr. Mahmoud Nozibur Rahman, to present his topic on treatment of the IBD associated arthritis. Dr. Mahmoud Nozibur Rahman, please.
Najib, unmute.
Assalamu alaikum. Thank you very much, moderator. I'm really honored and I'm really grateful to Bangladesh Rheumatology Society and BD physicians for giving me this opportunity to presenting something in front of my iconic teachers and all the rheumatologists, profound personality of this South Asia. So my part is treatment of arthritis associated with inflammatory bowel disease. And I think that Dr. Saskia has made my job a bit easy. She has covered up all the difficult things. And so I'm going to mainly focus on the treatment of IBD associated arthritis. So focus should be given on well-being of the patients as well as the disease manifestation as far as treatment of IBD associated arthritis is concerned. We should treat the patients for disease itself, and we should have another focus to improve the well-being of the patients by treating both intestinal as well as the articular symptom. So as far as the IBD associated arthritis is concerned, this job is a bit tough because in this subgroup of spondyloarthritis, patients also have another disease, which is intestinal disease, which is most of the time is complicated by some remitting as well as the severe disease. So here a multidisciplinary treatment should be the preferred one, where a rheumatologist and a gastroenterologist should be there to give a comprehensive treatment of this group of patients. So before embarking into the treatment, we should have a strategy, and we should assess whether this patient is having ulcerative colitis or Crohn's disease, or maybe sometime both part of this inflammatory bowel disease. And we should also assess which pattern of arthritis this patient is having. So today I am going to mainly focus on the articular part. What are the treatment of arthritis? I will not go through the treatment of GI symptom or GI disease. So I think this slide is worth to revisit again, because I think Dr. Taskia has shown already what are the types of arthritis. The arthritis are mainly in IBD are two types. One is axial, another is peripheral. So among peripheral group, there are another two types. One is mostly associated with the active disease, which is more of a reactive arthritis like. Another one is not associated with the bowel symptom, but it is progressive disease, though it is fortunately it's not erosive disease. So we have to categorize whether this patient is having axial disease or peripheral disease, or having both axial as well as the peripheral. So axial mean when the patient is having inflammatory back pain, inflammatory axial pain, and peripheral mostly when the patient is having predominantly large joint involvement or small joint involvements, which might be symmetrical or asymmetrical. So we have to categorize first. So I think this is a gross overview of the treatment algorithm. First, what we have to do, first we have to optimize the treatment of inflammatory bowel disease. Without treatment of inflammatory bowel disease, in some percentage of the cases where the bowel disease is not prominent, only the articular disease is prominent. In this case, we may follow this approach, but the prerequisite is actually control of the gut disease or the GI disease. So what we have to do, first we have to prescribe an NSAID to these patients, and NSAID has to be given for at least 14 days prior to assessing the response. If one NSAID fail, we can give second trial with another NSAIDs, and it should be given for another 14 days or 2 weeks. If we get the response, then that's fine. If we see there is a new or worsening of symptom of inflammatory bowel disease, in this case, we should refer the patients to gastroenterologist, whether there is chance of possibility of exacerbations of GI disease or NSAID induce some GI toxicity. And definitely we should discontinue NSAID in this group of patients. So after that, what we have to do, we have to assess whether this patient is having predominant peripheral arthritis or axial arthritis. If patient is having peripheral arthritis, our first choice of treatment will be conventional synthetic DMARD, which are mostly sulfasalazine, methotrexate. So we can try with sulfasalazine because sulfasalazine has got a bit evidence of efficacy in GI disease. So first line of treatment is sulfasalazine, and if sulfasalazine fail, we can apply methotrexate. So if the disease is controlled again, then we can continue this treatment. If the disease is not controlled, we should go for other options. So other options are biologics, that is biologics DMR. So here, as far as inflammatory bowel disease associated arthritis is concerned, the first choice of biologics is TNF inhibitor. So we can try with one TNF inhibitor, and it should be given for 3 months prior to seeing its inefficacy. So if the TNF works, that's good. We should continue the treatment. If it is not working, then we should go for another TNF. Or sometime we can, when there is some sequential failure of TNF inhibitor, then we can go for other options like tofacitinib or ustekinumab. So I will discuss elaborately about all these options. I just have given a brief overview about the therapeutic approach. So let's move to the first drug, that is non-steroidal anti-inflammatory drug. So non-steroidal anti-inflammatory drug is being a good options of treatment in spondyloarthritis, almost all type of spondyloarthritis. But the problem here in inflammatory arthritis, the patient is having GI disease, which might be exacerbated by using NSAIDs. So there is always a debate between gastroenterologists and rheumatologists whether to give NSAID or not. So as NSAID reduce the prostaglandin production by inhibiting COX-2 and COX-1, so there is chance of clinical relapse and exacerbations of inflammatory bowel disease. But the relationship has been very weak so far, and it is conflicting also, because there is one randomized control trial which has shown that most of the patients with IBD can tolerate NSAIDs, and 1 in 5 patients, that is 20% patient, may experience relapse, and that relapse is typically very mild, which does not require any escalations of IBD treatment. So this is a positive signal about using NSAIDs. And another large meta-analysis did not find any associations between NSAID use and exacerbations of IBD, that is ulcerative colitis or Crohn's disease. So before using NSAID, we can ask which type of NSAID we should use, whether we should use selective COX-2 inhibitor or just non-selective NSAIDs. So theoretically, there is a bit sense of safety about using COX-2 inhibitor because it is somehow GI protective. GI intolerance is less in COX-2 inhibitor, but American College of Rheumatology has recommended and suggested that there is no sufficient evidence to support use of selective COX-2 inhibitor over other NSAIds. That means we can use any NSAIDs provided the patient's acceptance and as well as the patient's tolerance. So we can say the short course of NSAID to treat arthritis are safe in patients with cushion IBD. So what are the challenges in the NSAID use? I already have given a clue. Say when we start or commence a NSAID for arthritis, so there might be 2 possibilities or 3 possibilities. One possibility maybe patient can tolerate their NSAID in most of the time. Another possibility is patient, there may be some GI intolerance or GI exacerbations. So which might be because of NSAID toxicity or might be because of just relapse of active bowel disease. So first we have to do, that is NSAID should be discontinued, and we should refer the patients, and there should be a dynamic dialogue between the gastroenterologist and rheumatologist about this issue. And I think the gastroenterology can see the mucosa, can stop the NSAID and see whether the mucosal inflammation is reducing, and by that way the gastroenterologist can confirm which entity is mainly dominating, whether it is NSAID toxicity or active bowel disease. So in summary, what we can say, there is a possibility of theoretical harmful effect, but the evidence is lacking, and short course of NSAIDs are reasonable option in patient with inactive bowel disease. So let's come to next part about the use of glucocorticoid. As it is inflammatory disease, autoimmune disease, the first thing that comes in our mind, whether is there any role of glucocorticoid? Definitely there is role. When the disease is active, when there is severe ulcerative colitis, the patient might require systemic glucocorticoid, sometime IV methylprednisolone. But for mild disease, we can give some local or non-systemic glucocorticoid. But for as far as the axial disease is concerned, when the patient is having predominant axial disease, the steroid is having no efficacy, or there is risk of adverse effect like osteoporosis. And we can give systemic steroid for very short durations, for very low dose, for severe flare of peripheral arthritis. And intra-articular glucocorticoid we might try in patient having monoarthritis or patient having oligoarthritis. So which glucocorticoid should we prefer? Should I go for prednisolone or budesonide? Say for mild disease, mild ulcerative colitis and Crohn's disease, we can choose budesonide because it has got a less systemic side effect and less effect on the bone mineral density. So what about using budesonide in inflammatory arthritis? I think so far there is no data of efficacy of budesonide in inflammatory arthritis. So in the setting of high cumulative dose of glucocorticoid, say patient having high disease, both intestinal as well as articular disease requiring long-term high dose glucocorticoid, and the cumulative dose is more than 5 grams, then we should screen the patients for the possibility of GIP and next treatment or treatment of GIP. And we should also look for the bone health by asking the patients about the exercise, adequate diet containing the adequate amount of calcium as well as the supplement of calcium and vitamin D. And also we should be very cautious about the growth retardations in patients having IBD with IBD in early age, say that is in children. So next options of treatment is conventional synthetic DMARD. So conventional synthetic DMARD have an important role in IBD associated arthritis, mainly the peripheral portions, not in axial. There is a little evidence of effectiveness in axial disease, but mostly it is effective in peripheral arthritis. So the CSDMR, what we have here is sulfasalazine. Sulfasalazine is considered to be the first line because it can have some benefit in gastrointestinal inflammations. Methotrexate will be the second when there is contraindications or side effect or intolerance of sulfasalazine, we can try with methotrexate. So sulfasalazine, what we have seen in trial of SPA, where the peripheral patient is having mainly peripheral arthritis, we have seen that 59% response rate in terms of both tender joint and swollen joint compared to 43% in compared to placebo group. So the sulfasalazine has got some efficacy in peripheral arthritis, but the problem is there is no superiority of response over placebo when the disease is axial. So maximum dose of sulfasalazine, what we can advise to patients is 3,000 milligram, that is 1,000 milligram 3 times daily. So sulfasalazine and mesalazine, these are the same group of drug. So, but the problem is mesalazine has got very little effect or little effect on controlling the inflammations of synovium, but it has got a good controlling ability in intestinal inflammations. So what about methotrexate? Methotrexate has got long history of use of peripheral arthritis in patients with SPA. No large randomized controlled trial has been tried in peripheral arthritis associated with inflammatory bowel disease. So mostly the data are incorporated from peripheral SPA, psoriatic arthritis, as well as the rheumatoid arthritis. So there is a small observational study found that methotrexate improved joint symptom in patient with peripheral arthritis and ulcerative colitis. And methotrexate can be prescribed as mono and combination immunosuppressive in inflammatory bowel disease. So it can be tried as a maintenance therapy in Crohn's disease. And a trial that is known as Meteor trial found that methotrexate did not improve maintenance of steroid-free remissions in ulcerative colitis, although there was a trend towards the increased level of remission. So what about azathioprine? Azathioprine can be used for maintaining the remissions in patients with IBD, both as a monotherapy as well as in combinations with other immunosuppressive. Azathioprine thought to have some effect on peripheral arthritis in rheumatic disease, but it is uncommonly used in SPA. So perhaps it is a blessing in disguise. So when we are using azathioprine for GI disease, we might have some efficacy in controlling the peripheral arthritis. So our next resort are biological treatment when both NSAID as well as the synthetic targets, conventional synthetic DMR fails. These are biologics, which is known as biologic disease modifying anti-rheumatic drug. So here tumor necrotic factor inhibitor, that is TNF inhibitor, are widely used in IBD associated arthritis because there is a substantial evidence of their effectiveness in both IBD as well as the SPA. So multiple large randomized controlled trial have demonstrated benefit in SPA patients with both axial as well as the peripheral joint disease. So what are the tumor necrotic factor inhibitor that has been tried in IBD associated arthritis? The infliximab. Infliximab has got some superiority in especially moderate to severe Crohn's disease as well as the ulcerative colitis in terms of promoting the fistula closure, promoting the mucosal healing, and sparing the use of steroid. And adalimumab is another TNF that is being proven effective in inducing as well as the maintaining the remissions in moderate to severe Crohn's disease as well as the ulcerative colitis. These two drugs are available in our country. We can use infliximab and adalimumab. Certolizumab, which is not available in our country but can be given in patients with Crohn's disease. Golimumab, which is another TNF, which is available in our country, can be tried in ulcerative colitis. So certolizumab in Crohn's disease, golimumab in ulcerative colitis. So what about another TNF blocker, that is etanercept? Etanercept has got positive effect on the joint disease, but it has got no effect, or rather there is associated flare of IBD, that is GI disease. So etanercept is not recommended treatment in inflammatory bowel disease associated arthritis, whatever it is, peripheral or axial. So our keen interest is on other group of drug, that is Janus kinase. So Janus kinase is not a biologics. It is called target synthetic DMR. They are non-specific immunomodulator treatment. So so in the year of 2020-22, so we see most of the disease are having some treatment option of this target synthetic DMR. This is kinase. So tofacitinib has been a good option in patients with ulcerative colitis and IBD associated arthritis. So I will show from which trial the result has come of efficacy in IBD associated arthritis. So the trial was Octave Induction 1 and Octave Induction 2 trial, where they have seen it is efficacious in terms of inducing the induction as well as the maintaining the remissions in severely active ulcerative colitis. So while a phase 2B trial in Crohn's disease suggested a minor treatment effect, and it was not statistically significant. So far we can say tofacitinib does not have approval for the management of the axial disease, although phase 3 clinical trial suggested efficacy of management in ankylosing spondylitis, that is axial SPA, and further studies are underway. We can see the patients having we have been using this tofacitinib in our country for axial SPA as well as the ankylosing spondylitis maybe for last 5 years. So and we have seen the efficacy in controlling the disease, and from that point we can say, and as well as the from ACR recommendations, of SPA, we can say tofacitinib can be effective in controlling axial disease of inflammatory bowel disease associated arthritis, and it should not be given. It should be noted that the tofacitinib has been tried at the dose of 10 milligram BD, that is 20 milligram BD in Octave Induction 1 as well as Octave Induction 2 trial. So, but the problem is recently we have received a black box warning about the venous embolism in using high dose tofacitinib. So it is a big problem. Say for severe ulcerative colitis, we have to use high dose tofacitinib, but it has got a risk of venous thromboembolism, where the disease itself also increases the risk of venous thromboembolism. as far as the IBD disease is concerned. So we have to categorize the patients, in which patients we are going to took tofacitinib as a first line treatment. So another interesting thing is upadacitinib, which is another Janus kinase, which is available in our country, has shown some efficacy in controlling the Crohn's disease as well as the ulcerative colitis in phase 3 clinical trial. So maybe upadacitinib is another options when the tofacitinib has got some problem. So this is the main that provider trial, Octave trial. Octave trial has got 3 portions. One was induction, Octave induction, and Octave induction 2, and Octave sustain. So here they have used 10 milligram BD dose for inductions of remissions. So those who have got some response in maintenance phase, they have given again randomized and enroll into 2 groups. One was maintained with 10 milligram BD, and another was maintained with 5 milligram BD. So the result was, as far as the induction is concerned, we have seen there's a significant rate of high induction of remissions in patient having tofacitinib 10 milligram BD compared to the placebo. And also Octave inductions 2 has shown the similar type of result, where we have seen that 16.6% rate of inductions in 10 milligram tofacitinib versus placebo. So Octave sustain, where they have used 5 milligram BD dose, and they have seen there is also some evidence of efficacy in maintaining the gut disease as well as the articular disease. So what are the non-TNF target biologics? Because what we have seen for last maybe 5-10 years, we have seen that other than TNF blocker, there are other biologics that are coming up. As far as we have gone in more deeper of pathogenesis, we have seen there are other cytokine involved other than the TNF. So ustekinumab, it is one of the human monoclonal antibody that binds to P40 subunit of both IL-12 and IL-23, and it is effective in controlling the Crohn's disease, which is refractory to TNF blocker. And in recent trial in ulcerative colitis has demonstrated the efficacy of ustekinumab, but ustekinumab have approved in both Crohn's disease and ulcerative colitis. The problem is it is only effective in peripheral arthritis, which is associated with inflammatory bowel disease, but it is not effective in axial disease. So this is the one problem. So other non-TNF blockers are secukinumab and ixekizumab. These are mainly IL-17 blocker. So there are some trial about using secukinumab in IBD-associated arthritis, and what they have seen, secukinumab has rather increased chance of flare in patients with IBD. So it is not recommended, and it should be avoided in patients with IBD. So in treating a patient with axial SPA having some covert GI involvement, or treating a patient with psoriatic arthritis where there is concomitant some GI involvement, which is very common, I think we should be very cautious about new onset of GI symptom in those patients while we are treating patients with secukinumab, so as well as the ixekizumab. So these 2 drugs should be avoided in IBD-associated arthritis, but we should be very vigilant in treating patient SPA as well as the psoriatic arthritis, whether these patients develop any GI toxicity in terms of say new onset IBD or flare of IBD. So what about other biologics? One of is abatacept, which is CTLA-4 inhibitor. It is mainly inhibiting the stimulations, that is co-stimulation between T cells, but it did not demonstrate efficacy for the management of IBD. Tocilizumab, IL-6 inhibitor, by the blessing of COVID, we have known this drug and extensive use of this drug. I think it is one of the good options of treatment in rheumatoid arthritis, and it is tried in patients with SPA as well as the IBD-associated arthritis. But what they have seen, there is incidence of intestinal ulcer as well as the intestinal perforations, and it is not an ideal choice. We should avoid tocilizumab in this group of patients. So the newer options is, I think, from the pathogenesis, what Dr. Taskia has shown, there is an important provider role of integrin, alpha 4 and beta 7, and it is one of the molecule as a molecule or chemical in the pathogenesis of IBD associated arthritis. So monoclonal antibody against the integrin alpha 4 and beta 7, which is known as vedolizumab, has been tried in ulcerative colitis and Crohn's disease, and they have seen in Gemini trial that it has got a good efficacy in the controlling GI disease, but it has got no efficacy in controlling the articular portions. So it should not be given patients having arthritis. Rather, we can try this drug when it will be available in patients having prominent GI disease. So what about using probiotics? Probiotics are widely used among the patients with IBD. There is mild evidence of benefit in ulcerative colitis when the patient is having JPOS or bursitis, but there is no evidence of their effectiveness in Crohn's disease. So probiotic were not effective in SPA that we can say, and there was one small study which also shown that statement. So there is currently no evidence to support the use of probiotic in IBD associated arthritis. So I think the main important thing of my these presentations is actually it is very important and it is very relevant in using in tofacitinib as well as the biologics is pre-treatment screening and risk. So before using biologics as well as the Janus kinase in whatever the disease, I think the principle will be the same. What we have to do, we have to screen, we have to take patient history and detailed physical examinations and to exclude active as well as the hidden infections like latent TB infections, active TB infections, deep-seated abscess anywhere or deep-seated abscess in fistulizing Crohn's disease, any dental infections like asymptomatic urinary tract infections, any deep-seated fungal infections or hidden fungal infections, as well as the malignancy. What we have to do, we have to definitely assess and update the vaccination status. Prior to giving biologics as well as the Janus kinase, we have to very meticulous and vigilant about giving all this vaccine. Definitely, we have to vaccinate the patients with influenza yearly. We have to vaccinate the patients with pneumococcal conjugate vaccine first and pneumococcal polysaccharide vaccine after conjugate vaccine. And also, we have to screen the patients with for hepatitis B and C, and we should vaccinate the patients with hepatitis B virus vaccinations. And it is also relevant. We should also ask about the COVID vaccinations, and especially those patients are going to receive the tofacitinib. We should also try to arrange giving recombinant zoster vaccine in patients who have already evidence of varicella, because with the treatment of tofacitinib, there is a good possibility of reactivations of varicella zoster. And also in patients, those candidate patients should receive the human papillomavirus if it is possible, and we should avoid live vaccine. And also we have to do some investigations. I must say it is extensive in investigations about renal function, liver function, as well as the full and differential blood count. And we should do fasting lipid profile, mainly the HDL level prior to starting Janus kinase, especially the tofacitinib. And we should screen hepatitis B with HBsAg, anti-HBsAg antibody or anti-HBc core antibody, with or without hepatitis B virus DNA. Sometimes DNA might be required. So hepatitis C virus screening should be done with anti-HCV antibody, anti-HCV RNA testing if antibody is positive. And one thing is very important, because we are endemic TB country where the latent TB infection as well as the active TB infection is quite prevalent. We should screen the patients for active TB infection as well as the latent TB infection. As far as the national guideline, we can do chest X-ray. If we find any suspicion lesions in the chest X-ray, we need to do sometimes contrast enhanced CT scan. And also we can screen latent TB infections with quantiferon TB-Gold plus preferably when it is possible, or we can do it by Montu test. But sometimes we need to do both in some selected patients. And in patients having say suggestive history of having a high risk populations of having human deficiency virus, we should screen the patients about the human immunodeficiency virus also. And another important thing, patients having risk factor for venous thromboembolism, especially patients had prior venous thromboembolism, or patients is on OCP, or because of some hemophilic condition, coagulopathic conditions, we should screen those patients prior to starting high dose Janus kinase inhibitor. So in nutshell, what we can say, non-biologics treatment, mostly the methotrexate, sulfasalazine, and azathioprine are effective in both peripheral arthritis, as well as it is effective in IBD. And TNF is good choice, and adalimumab, infliximab are mainly two drugs effective in both peripheral as well as the axial disease, as well as it is equally effective in IBD, whatever it is, ulcerative colitis or Crohn's disease. We can see IL-12-23, that is ustekinumab, which is not available in our country, but it has got some efficacy in both peripheral arthritis as well as the IBD, but axial disease has got no effect. IL-17 should be avoided because there is risk of gut perforations, and CTLA4 has got no role. JAK inhibitor, this is one of the drug of concern and a drug of interest which is available in our country. It is effective in both severe as well as the mild to moderate ulcerative colitis. It is effective in both peripheral as well as the axial disease, as far as the data that we have received from phase 3 clinical trial. IL-6 should be avoided, and this drug vedolizumab is not available in our country, but it has got a good gut specificity, and it can control the gut disease, but it has got no efficacy in SPA, the articular disease. So this is another thing. I think the same thing that we can say with some reference. And this is one slide showing the different CSDMR as well as the target synthetic DMR as well as biologics that we are using, and with some comorbidities. So thank you very much to all the participants and all the audience for patience hearing.
Thank you, Dr. Mohammad Mojur Rahman, for his brilliant and informative lecture covering all the aspects of the articular manifestations of inflammatory bowel disease. Now it is the time to have the question and answer session. So now chat box, we see a good number of questions. So it indicates there is a huge enthusiasm among the participating audience. So I would like to refer the first question, the initial question, to the first speaker, Dr. Taskia Hawk. Dr. Taskia Hawk, please. But the first question is, can the extraarticular manifestations be the first presentation of inflammatory bowel disease patients?
Thank you for the question.
Can
the extra intestinal manifestation can be the presenting feature of IBD? Is this the question?
The question is that can extraarticular manifestations be the first presentation of an inflammatory bowel disease patient?
Inflammatory bowel disease patient has some extraintestinal clinical features. Among them, there are articular and extraarticular. And IBD patients may present with extra intestinal, that is articular and both extraarticular manifestation as their presenting feature. Although I don't know any statistical reference, I think panelists may update me in this question.
Okay, so I think that the question can be also answered by any of the panelists like Bhushain sir or Meena sir or Siddharth sir, regarding that whether can be the extraarticular manifestations be the initial manifestation in a patient with inflammatory bowel disease.
Yes, yes, definitely. Is there anyone to answer or make any comment? I think Kalum Deshapriya
or
still
Kalum,
is here. Dr. Kalum can make any comment if he is here.
Yes, I mean, any combination of presentation is quite possible. Yes, the answer is definitely yes. Yeah, as she said, now, I mean, it is very difficult to find literature as far as the statistics concerned, but presentation is quite possible. Yes.
Actually, if the patient don't have any feature
Yes, so we
of,
have to keep it in
I-
mind that this a patient is having inflammatory arthritis associated with inflammatory bowel may present with arthritis. Now, um, I think the question, I had some internet problems and I missed the question perhaps.
the
Whether
question was,
he wanted to know that is there is any percentages or something. Najib wants to tell anything, or do you want to add anything, or?
Sir, yes, sir. Thank you very much. I think it is possible. I am absolutely agree with Kalum, sir. It is absolutely possible, and interesting fact that we have seen those patients with ankylosing spondyloarthritis or SPA patients or psoriatic arthritis has got some underlying covert GI inflammations, and which is evidence in which is being found in scopic sometime as well as some histopathology. So what we can say, prior to having some GI involvement, patients might have some extraintestinal manifestations in term, say, by some arthritis, some venous thromboembolism, pyoderma gangrenosum, uveitis. These are the things that can be present. But so far, we have not encountered any specific literatures like the percentage of whatever the percentage, but it is possible. It is definitely possible.
okay, thank you. We are proceeding towards the second question. In polyarticular variety, how common in polyarticular variety of inflammatory bowel disease, how common is the DIP involvement?
The polyarticular variety, the most commonly affected joints are metacarpophalangeal joints, followed by knee, ankle, wrist, or MTPs may be involved. But specifically regarding DIP involvement, I could not find anything specifically as far I have searched. Panelists may
Okay, we are
add
again.
something.
Thank you. Then we can turn this question to our respective panelists like Dr. Kalum Deshapriya sir or anybody else from this panel session.
Shaheen, do you want to make any comments on these?
actually in our practice, so far I know the polyarticular presentation is not common. I think, and usually we have not so many patients encountered so many patients of IBD related with articular presentation. So far I know the oligoarticular presentation is common in IBD associated arthritis.
Yes, in my induction comments, I have said it's not that much common. I think Roshan wants to make some comments. Roshan, Professor Roshan, how much
yes.
you encounter?
Now that is true. We do not have. Thank you very much. We do not have any statistical data, but these are not very common to find arthritis in a patient of IBD, and polyarthritis or skeletal or central arthritis involvement is also very rare. But few of the patient of IBD also complains of back pain. But when we meticulously went for investigation, only one or two or only few cases of them are revealed to have definite degenerative or erosive arthritis or ankylosing spondylitis specifically. So peripheral involvement in the form of arthritis and arthalgia is found in some cases of IBD, but that is not very common in most of the cases of IBD. Moreover, I want to mention one thing, that among the two IBDs, that is Crohn's and ulcerative colitis, Crohn's itself is not that much common in our country. So Crohn's associated arthritis is also not very much encountered in our day-to-day practice. Thank you very much.
Okay, we have
in general, I think in general, we have to remember that this presentation could be like mostly like spondyloarthritis like presentation. So the large joints involvement, axial involvement, and nowadays even the Tachkia, probably she had shown nicely that the type 1 and type 2 arthropathy, etc., etc. And nowadays there are literatures that people are not depending on this kind of differentiations. So we have to remember the peripheral arthritis is possible, peripheral involvement, and the most likely the patients may have the presentations similar to spondyloarthritis. And definitely polyarticular is a very unlikely that a presentation will be polyarticular. But in medicine, what I always try to tell to our students that it's not possible, better not to say impossible or not possible, or again something. So we have to be very cautious of using this kind of word. So in medicine, possible, everything is possible, but common things should be considered first. Thank you.
Okay, we are proceeding towards this third question. The third question is towards the second speaker, Dr. Mujibur Rahman. Is there any role of opioids, for example, tramadol or tapentadol, in the management of IBD-associated arthritis?
I think these two drugs cannot control the disease, but it can alleviate the pain. So the patients having some definite contraindications about using these NSAIDs, say definite GI intolerance because of NSAIDs, or some GI erosion, some other issue, or because of heart failure, renal impairment, where we cannot control, we cannot advise NSAIDs. In these conditions, for the ameliorations of the pain, we can consider opioid or tapentadol, but provided we should look for their deleterious effect on the gut disease, because the opioid as well as the tapentadol has got, say, sometime it might induce constipations, some might causes low increased GI transit time, and that might aggravate the GI symptom too. So we can use this two drug for the relieving the pain, but it will not control or control the disease. In selective patients, we can use those who are having contraindications, but we should be very vigilant about their GI toxicity also. They are not that GI friendly drug also, because sometimes nausea, constipation, these are the quite frequent adverse effect of opioid as well as the tapentadol. Thank you very much.
Okay. The fourth question is, should we screen every patient of psoriatic arthritis? Should we screen every psoriatic arthritis patient for inflammatory bowel disease, since psoriatic arthritis may present with overt GI symptoms or covert GI symptoms? So this question is open for both of the speakers. So I think that anybody of you can answer.
So earlier I have mentioned, this group of disease, that is spondyloarthritis or spondyloarthropathy, they have a considerable overlap in terms of both articular, non-articular GI. So SPA patient might have some covert GI involvement. Psoriatic arthritis patient might have some covert GI involvement. But as far as their symptom is not that overt. Say psoriatic arthritis patient having covert GI inflammations, but the symptom is not there. So I think we should not go for doing extensive evaluations, say by doing some endoscopy or any other things. But whatever the symptom is prominent, patients is repeatedly complaining of some GI symptoms, say abdominal pain, chronic abdominal pain, weight loss, signs of malabsorptions, sign of steatorrhea, or both small as well as the large gut dysfunction. We should definitely go for screening by doing endoscopy and some other tests like fecal calprotectin, and we should effectively treat those GI disease with the help of our respected gastroenterologist, sir.
As the question is regarding screening, I want to add that subclinical gut inflammation is present in about 2/3 of SPA patients. So if we want to screen those population, it will not add anything in the management of the patient, only increase the cost of the treatment.
Suffering also.
So definitely Professor Roshan is here. If there is any high index of suspicion that our patients may have either Crohn's disease or ulcerative colitis, we have to make it confirm, and we have to refer this case to gastroenterologist. And Dr. Najib and Tazkia already told fecal calprotectin is very important. I think very valuable marker, because it can differentiate between irritable bowel syndrome from the inflammatory type. So inflammation is there. So there are opportunities. And I think here also Professor Roshan can make any comment. And Kalum also may make any comment in your Sri Lanka experience.
Let us start from me. Thank you very much once again. Yes, ankylosing spondylitis patient may have subclinical inflammatory changes in the gut, mimicking or the undiagnosed form of IBD. And the treatment in both the cases, both the IBD and arthritis are supportive. We can only relieve the symptom of the patient by giving treatment, and we can also keep the disease under control with treatment. If the patient is not symptomatic, and as the treatment modalities are to some extent different in the early stage of the disease, as for example, if the patient has arthritis only, and there is the treatment is done with NSAIDs and others, then I don't think that it will be of very good help to evaluate GIT, because if it is the disease, the treatment is to some extent different, and that treatment probably will not add any benefit on the top of NSAID, which are already being able to relieve the symptom of the patient. But if the symptoms are prominent, that is, the patient has, or that is, bowel habit is more than usual, or the patient is passing blood or mucus frequently, or patient is malnourished, then definitely we go for investigation, including to start the non-invasive, the fecal calprotectin, and then we should go for endoscopic investigation and biopsy. That will give the diagnosis. And if it is there along with the symptoms, then we shall have to treat both the IBD as well as the ankylosing spondylitis. In some cases, the same treatment can relieve both of the symptoms. So initially, what I want to emphasize is that if the patient has only symptom of pain, especially in the peripheral joint, having no GI symptoms, it is better not to go for extensive investigation of the GIT. Thank you very much.
Dr. Shoaib, can I add one thing?
Obviously, sir. Obviously,
Roshan sir has mentioned nicely. And on the other hand, if patient does have GI symptom, IBD, prominent IBD, with a mild symptom of arthritis, joint symptom, in that case, patient need not to evaluate for arthritis or need not to treat arthritis. In that case, if we treat adequately IBD, in that case, arthritis may be subside in that case. Thank you.
okay, thank you, sir. So I think that there is a strong enthusiasm among the participants, and still now we are encountering many more questions. So as we have time shortage, so I think that we can proceed towards the final question. And the final question, in peripheral predominant arthritis in a patient with inflammatory bowel disease, if the sulfasalazine fails, is there any scope for combination CS disease modifying drugs or switching to another CS disease modifying drug? So I think that Dr. Najib can answer this question.
Yeah, as far as the IBD associated arthritis is concerned, say the treatment options or therapeutic strategy that we are having, actually these are extrapolated from the data of treating psoriatic arthritis, rheumatoid arthritis, and peripheral SPA. So far there is no trial of combinations of CSDMR in peripheral SPA, but of course we can try both combinations, sulfasalazine or methotrexate. But the recommendations so far from the bodies, different society, are when they are having refractory disease, go for TNFI or any other, say sometime we can choose for Janus kinase inhibitor. But from that perspective, we can say we can combine this CSDMR. But so far we don't have any strong evidence or a strong support or any well-controlled trial which is giving a strong reports of efficacy of combination CSDMR.
I want to add one point to Dr. Najib's comments. Yes, the modern medicine is the evidence-based medicine. Unless there is evidence of combining one or two non-biologic disease modifying agent for the treatment of spondyloarthropathy associated with IBD, so it is better not to go for that. We can try it, and if there is any benefit, then only we can recommend. But so far the recommendation is not to go for the combination, but to go for the biologics next to methotrexate or sulfasalazine or azathioprine. So after using one after another of these drugs, we shall have to go for, because there are many people who cannot tolerate sulfasalazine. So if we start with the sulfasalazine, and if it is not well tolerated and not very much effective, then we can go for methotrexate and azathioprine. That can be tried. And only then, if these are failed after 2 to 3 for at least 3 months, then we must have to go for the non-biologic biologic agent TNF and antibody. So thank you very much.
Yes, agreed. So we have to follow the recommendations so far. And
but my question to Najib, if patient do have axial disease, don't have prominent peripheral disease, and should we go for this sorts of synthetic DMARDs, and especially methotrexate? Is there any good evidence of methotrexate to use both these sorts of arthritis and IBD? Should we go for methotrexate? How strong your evidence for methotrexate?
Sir, so far, as far as the axial disease is concerned, not having any peripheral disease, methotrexate has got no efficacy over axial disease. So there is some paper supporting use of sulfasalazine in axial disease, but they are actually very poor quality evidence. But in country like say poor resource country having say where the patient cannot afford biologics or sometime target synthetic DMR, we might try sulfasalazine in axial disease. But so far methotrexate has got no evidence of efficacy in axial disease. So sulfasalazine might try, but so far the recommendations is actually using TNFI when there is axial disease, when NSAID failed, 2 subsequent NSAID failed. But as of now, we are having another options, which is a bit definitely affordable by the patients, that is tofacitinib or sometime upadacitinib. We might try these 2 options while the sulfasalazine fails. But recommendations is actually against using methotrexate in axial disease, against using sulfasalazine in axial disease.
so this is just the message is, this is just like our axial spondyloarthritis, treatment of axial, and as well as treatment of peripheral spondyloarthritis. The recommendations of using these drugs, sulfasalazine or methotrexate, are the same. So we have to keep it in mind. We are fortunate that we have the JAK inhibitors now available at a lower cost. But again, we have to remember the recommendations and the judicious use of these drugs. The rampant use of these drugs are bringing huge problems. And Dr. Najib, in his presentation, he said just regarding deep vein thrombosis, but there are several other adverse effects too. We have to remember major cardiac events, malignancy. So everything has to be kept in mind, and even the herpes zoster. So these are the adverse events. Thank you.
So we have come towards the end of the today's question and answer session. So now we'll proceed towards the comments from our panel of experts. Before that, I'd like to thank all the participants for their vibrant participation and very encouraging participation in the form of multiple questions. There are so many questions that we have failed to answer all the questions due to the shortage of time. So thank you, everybody. So now we proceed towards our panel of experts. So the first panelist will be Dr. Kalum Deshopriya, sir. He is from Sri Lanka. Sir, would you please make some comments towards today's discussion?
Yeah. Thank you very much, Professor Minhaj, and I would like to thank the Bangladesh Rheumatology Society for inviting me. So I'm really encouraged to see the enthusiasm shown by the participants. Number went over 200, and even now you are joining about 160 participants. So that shows the enthusiasm. Congratulations and best wishes for the Rheumatology Association. So I would like to congratulate both the speakers who have done their work, extensively read and presented their presentations very well. To follow your presentation. Apart from that, there is nothing else that I should say. Excellent presentation, good work. Congratulations. Thank you very much. Professor Minhaj and Society and all the participants. Thank you very much.
Thank you, sir.
Thank you, Dr. Kalum Deshopriya, sir, for your valuable comments. So I proceed towards our second panelist, Professor Dr. Mohammad Abu Shain, sir, to express his valuable comments regarding today's presentation.
Thank you. Respected chairperson of today's session, Professor Syed Atikul Haq sir, respected our today's guest panel of experts, Dr. Kalum Deshopriya from Sri Lanka, and another panel of experts, my teacher, Professor A.S.M. Roshan, renowned gastroenterologist of our country. It is my privilege to join this webinar as a panel of experts. I must say, the topic of today's discussion is very, very important. And I have learned many things from both of the speakers as they nicely, deliberately present their topic. And Dr. Taskia nicely mentioned all the aspects, especially ASAS criteria, pathophysiology of spondyloarthropathy, with so many hypotheses with IBD. And I also thank our second speaker, Dr. Najib. I know him. 2 or 3 important aspects he mentioned. This is really interesting, and we have to learn, especially one for NSAID. He has shown many references that there is no relation of NSAID with IV exacerbation. Actually, I think this is new for many of our junior doctors, and I expect the comment from our Professor Roshan sir from his talk. And so far we know once upon a time COX-2 is superior. Sometimes we fear GI upset with other NSAID, and we think COX-2 inhibitor, celecoxib, etocoxib is sometimes better. And Dr. Najib nicely mentioned there is no superiority of COX-2 inhibitor with other NSAID, and short course of any sort of NSAID we can use. And another important thing, after use of NSAID, Dr. Najib mentioned tofacitinib we can use in our country. This is a good drug, and this is a low pricey drug, and TNFi is still in our country available, but cost is too high for our country people. Should we use tofacitinib without giving TNFi? I expect talk from our Minhaj sir or Soed Atikul Haq sir. Also, Roshan sir may give in his speech some comments, and they are using Bangladesh and rheumatologist, gastroenterologist in our country, are they using tofacitinib for ulcerative colitis or IBD, and their experience. And I want to know, Professor Roshan sir, how many patients, how frequently he encountered their toxicity with NSAID. As Najibur Rahman mentioned, there is no relation. I like to know. And this is my curiosity that, and this is very important information, that etanercept and secukinumab, these two biologics we are using in our country. But important thing as these two biologics exacerbate the IBD. So thank you very much for this webinar organized by Bangladesh Rheumatology Society. Thank you.
Thank you, Professor Abushan sir, for your very good comments and some practical talking or touching on some practical aspects in the IBD associated arthritis management. So it is the part for Professor H.M. Roshan sir. So I think that Roshan sir will answer the rest of the questions or queries that have been put by Professor Abushan sir.
Thank you, sir. Respected chairperson of today's session, Professor Soed Atikul Haq, who is our teacher. He was not my teacher, he's still my teacher. And we learned many things from him, and we have been learning. So it's my great pleasure to be here by the invitations of Bangladesh Rheumatology Society to learn many things. I have nothing to teach, but I could learn many things, because rheumatology we have not been reading, and also we are not treating these cases for a long period of time. So by attending this seminar or webinar, whatever we call, I personally was benefited to learn many of the things. To answer to the question, not actually question, an issue, that is the use of NSAIDs in case of ankylosing spondylitis. NSAID is not required for the treatment of IBD in our situation. So flaring of this disease we usually do not encounter, but it is known that NSAID flares the mucosal lesion, sometimes it's defense. So it is commonly not recommended for using NSAID, but some of the COX-2 inhibitors have been proposed to be better than conventional NSAID for the treatment of ankylosing spondylitis, have been shown to have less deleterious effect than the NSAID. Even then, there are many evidences which show that the NSAID itself or COX-2 inhibitor specifically sometimes exacerbate the symptoms and patient cannot tolerate. But also there are evidence, as Professor Najibur Rahman mentioned, that many of the patients do not have the exacerbation of the symptom, and this can be used. So it is not that straight away we can say this cannot be used, and we also cannot say we can use. So we may use when it is necessary, when there is peripheral involvement of the joints with ankylosing spondylitis associated with IBD. If there is no flaring of the symptoms, we can continue. But if it is, then we shall have to go for further investigation to see whether there is any exacerbation of the mucosal and other lesions of the ankylosing spondylitis. That I think should be better way to treat these cases, because there is nothing in clinical medicine to say yes or no in most of the situations. This is from my side. And the other tofacitinib, yes, the other issue which has been raised, that tofacitinib is used in some of the cases of IBD, but not all. The response is good, but side effect and other has not been well studied. So only one thing I can say, yes, gastroenterologists are also use tofacitinib in some cases. I cannot control myself without describing. This is my last comment. I cannot control by saying few words regarding the discovery of treatment of ulcerative colitis, especially. We know Professor A.K. Azad Khan, he went to UK, he went to Oxford, when there is no basic differences. These differences could not be made between ulcerative ankylosing spondylitis and rheumatoid arthritis. Arthritis was the common problem, and people did think that this arthritis was an infective disease. And sulfur was then only in the initial stage the chemotherapeutic agent. So they would use sulfasalazine for the treatment of arthritis, peripheral arthritis, I must say. Now it has been proved because these are the ankylosing spondylitis, the IBD associated. So the patient in response mentioned that when we take sulfasalazine for the treatment of arthritis, few of them had bleeding per rectum. They mentioned that my bleeding per rectum and GI symptoms are relieved. That actually attracted the attention of his boss, Professor Trulab, who actually asked Professor A.K. Azad Khan to go for studying. And it was found through his research that the two elements, there is sulfapyridine and 5-aminosalicylics are two components. And it is the 5-aminosalicylics which are effective, and sulfapyridine is effective for the treatment of ankylosing spondylitis. And ultimately, this could be separated. That lead him to be awarded the doctorate. That is, he was awarded DPhil degree from the Oxford University through the research and others. So these are the story. This is the important story we must remember. And fortunately, this was discovered by one of the greatest sons of this country, Professor A.K. Azad Khan. So with these few words, I would like to finish my today's talk, and I must express my great gratitude to Bangladesh Rheumatology Society, specifically my friend Professor Minhaj Rahim Choudhury, who have created this opportunity to be with my few known people in one session. And I passed very good time for last 1 and 45 minutes times with you. Thank you very much. Thank you once again.
Thank you, Professor H.M. Roshan sir, for his very nice comments and issuing all the issues raised so far. So we are proceeding to the comment of Professor Minhaj Rahim Choudhury sir. He is also the secretary of Bangladesh Rheumatology Society. So I'd like to request Professor Minhaj Rahim Choudhury sir to express his comments.
Thank you, Dr. Shoaib, Mr. Chairperson of this session, Professor Syed Atikul Haq, dear panelists, speakers, moderator, and learned audiences. It's a satisfaction that we have organized this important webinar, and definitely we are grateful to our two guest panelists. Special thanks to again Dr. Kalum Deshapriya and from Sri Lanka for showing his keen interest in our webinar. And so they are in a little bit bedtime, and he has joined from the darkness, we have seen, and they have not a problem with the electricity. He told me it's like 10 to 12 hours they have load shedding, long electricity cut. So thank you again, Dr. Kalum, and my friend Professor H.M. Roshan. Also, we are grateful to him for his kind participation, and very interestingly, you see what Professor A.K. Ajad Khan did during his tenure in UK. And I think very few people of us, I heard about it, but very few people of us we know in detail. Thank you, Roshan, for enlightened us with this information again. So today we had two speakers, and both of them were, I must say, outstanding. I'm pretty sure all of the participants were benefited from their deliberation, and definitely I personally learned a lot. First speaker, Dr. Tajkia, she spoke on how the patients can present, how to diagnose, and she talked on the use of MRI, fecal calprotectin, and the future use of sclerostin and beta-2 microglobulin. We are hopeful these things also will come up. She also spoke nicely on how to monitor these patients. And second speaker, Dr. Mohammad Najibur Rahman, also brilliantly talked on how to manage. He spoke on the use of NSAIDs. There are lots of debates. And really these things are challenging because one patient when comes with the, you see, when the GI upset, GI problems, then using NSAIDs is a big challenge, a huge challenge. I'd like to request also during his speech of our chairperson, he will also make some comments. How does he handle this kind of situations? And every drug, although Dr. Najib told that there are no differences, but we try to, there are some literature supports, and I personally try to use and this kind on these situations, etoricoxib now. Regarding Dr. Najib also nicely discussed on the use of corticosteroids, and I must say for the participants that don't forget about the judicious use of the steroids. I'd like to request you, our young colleagues, that try to avoid steroids, corticosteroids, because we have several options nowadays. And if we are compelled to use, then try to remember in the literature, if you see, you will find that they have used the word bridge therapy. So here in this situation, and one question was there probably, whether we can use corticosteroid or not. So yes, in the literature it is there, but it should be bridge therapy and it should be withdrawn as early as possible. And nowadays always we tell that we must try to withdraw it within 3 to 6 months time. And definitely regarding the use of biologics, and we will have biosimilars also in our country very soon, like infliximab, and I think infliximab is very much useful. And I have some reports from our overseas colleagues, doctors. They use their IBD associated arthritis patients usually infliximab, and they are getting very good results. In Bangladesh, it is very costly, and I rarely use in my patients. And again, tuberculosis is another problem while we use infliximab. So these are the issues, and probably still adalimumab is a better option, although our chairperson, he may have some different thought. We will listen to him. And another good option is golimumab, also available in our country, but definitely these things are very much expensive, we have to remember. So again, the JAK inhibitors, and these are all under trial, and we are optimistic that this could be used and will be recommended in future very nicely. Again, we have to remember, and I'd like to request our junior colleagues that the rampant use of JAK inhibitors should be avoided. And the participants here who have participated, they should tell their colleagues that whenever we wish to use tofacitinib or baricitinib or upadacitinib, this should not be prescribed like this. There are some necessary preparations and necessary screening, what Dr. Najib mentioned nicely, whether we are putting our patients on vaccines and all the screening for latent TB, hepatitis C, all things should be kept in mind before writing in your prescription tofacitinib. Don't run for that, don't jump for that. That is like, this drug is not like a painkiller. You have to understand these points. We are very much thankful to our scientific partner, BD Physicians, and special thanks to Dr. Ehsan and Onik. Dr. Ehsan is I must say, is a very dynamic person. I have asked him just 3 to 4 days time, I have just talked to him and he organized this webinar so nicely. I am very much impressed on him. Finally, I am showing my gratefulness to all audiences and our moderator, Dr. Shoaib Momen. He also conducted the program very nicely. So with these few words, I would like to conclude my comments. Thank you everybody for patience here.
Thank you, Professor Minhajur Rahim Chaudhuri sir, for his excellent words. So it is the talk on behalf of the chairperson of this today's session, Professor Syed Atikul Haq sir. He is the president of Bangladesh Rheumatology Society and ex-president APLAR. So Professor Syed Atikul Haq sir, please.
Okay, thank you very much, Shoaib, for giving me the opportunity of talking in this webinar. Firstly, I should express my heartiest gratitude to Dr. Tazkia and Dr. Najib. Both of them, they have very seriously prepared their talks and they have studied the literature quite extensively. In fact, I was very keen to find out any flaws at any point whether they have missed, but I couldn't find anything that they have missed. So that it's an excellent, and I would say in a short time, it has been a quite complete presentation. I also appreciate the audience. Actually, the number of audience went up to 170. That is a quite large number. And now still there are 141 are adhering. So at the end of 2 hours, it's a quite impressive number. Then, I would say more than how much? More 80% adhering to the session at the end of 2 hours. It is quite extraordinary for any international events. So, and also I thank the panelists, all the panelists, but particularly Professor Kalum Deshapriya, he is my good friend, and also Professor Roshan, because they don't belong to the fraternity of Bangladesh Rheumatology fraternity. So they're truly guests and they have agreed to be present here despite their other commitments, and also have, they're attending this session up to the end. I thank them very much. And BD Physicians also owes a great thank from me. And I should just raise, I should discuss a few, I can say 3 points from this talk. Number one is about NSAID induced, I would say, whether NSAIDs exacerbate inflammatory bowel disease. That was the first question. In fact, NSAIDs may cause multiple forms of colitis, like, hemorrhagic colitis, necrotizing colitis, membranous colitis, pseudomembranous colitis, and collagenous colitis. Many types of colitis, and also NSAIDs may cause enterocolitis involving inflammation of the mucosa of small intestine is also possible with NSAIDs. Even sometimes such inflammation may lead to intestinal adhesion, then fistula formation. These things may also occur. But all these GI side effects, other than upper GI, other than, peptic ulcer disease, all these things are very rare. That is the first point. But, these things has not found to be more common in patients with inflammatory bowel disease. There is no proof that, these colitis, these types of colitis occur at a greater frequency in patients with inflammatory bowel disease. That is one thing. And also, as I would say, as Najib has already mentioned, that in a large meta-analysis, it was ruled out that, NSAID may cause exacerbation of, ulcerative colitis or Crohn's disease. So in patients who benefit from NSAIDs and who can tolerate NSAID, in whom there is no apparent exacerbation of IBD with NSAID, we may continue till the disease-modifying drugs take their effect. That is, as a bridge therapy, as Minhaj has already mentioned about the bridge therapy for inflammatory bowel disease-associated arthritis. NSAIDs are better bridge than glucocorticoids. That is number one point I have to clarify. My number 2 point is one of my personal observations. That is, I have found many patients who had some spondyloarthritis, and I gave sulfasalazine for control of that, spondyloarthritis. You know that there are current, research findings that sulfasalazine is not effective in axial form of spondyloarthritis. Despite that, we give it because the alternatives are much more expensive. So we are bound to give it sometimes, and we give it quite liberally in patients with peripheral spondyloarthritis. And I had many patients who, along with spondyloarthritis, also had irritable bowel syndrome. It means that they were diagnosed as a case of irritable bowel syndrome, but after starting sulfasalazine, they reported that the symptoms of irritable bowel syndromes have miraculously disappeared. That was my personal finding, and actually I was telling these things to our colleague, Professor Nazrul Islam. I think it was before 15 or 16 years, and Nazrul, along with the help of Professor Mahmoud Hassan sir, they actually organized a research on inflammation, histological inflammation in patients with ankylosing spondylitis in colonic inflammation. And this colonic inflammation was found in all patients with ankylosing spondylitis. That was subclinical. There was no clinical symptoms, and even there was no, macroscopic colonoscopic abnormality. So that was absolutely subclinical, and that was very common. So I think, these so-called irritable bowel syndrome might have represented mildly symptomatic patients with, microscopic colitis. I cannot call it subclinical because they had features suggestive of, irritable bowel syndrome. So I would request Professor Roshan to, collaborate with our colleagues to, to explore this aspect more widely. And also, I think, irritable bowel inflammatory bowel disease and inflammatory bowel disease associated arthritis, though they are said to be rare, I think they are not rare. Maybe they are uncommon, but they are not rare in our country. I think, I have approximately 10 patients of inflammatory bowel disease in my follow-up, since I see a small number of patients. So, 10 patients is not a, very low number of patients. So they may not be as rare as they are thought to be. That is my, second point. And my third point is, that this is particular. I think Roshan is here. Roshan, are you here?
Yes, sir. I'm here, sir.
Okay,
I'm listening.
thank you very much.
I'm listening, sir.
Roshan is one of my most favorite students. Though
Thank you, sir.
Roshan is now among the, sadly, among the senior gastroenterologists, despite, being my student. I think you are among senior, isn't it?
No, sir. I'm still a student and a student to you for rest of my life, sir. Thank you.
But
I may be senior by years, but not by knowledge, sir.
No, you have to influence the gastroenterology fraternity, because, this was my experience that, whenever I give a patient sulfasalazine for control of IBD associated arthritis, and the patient goes back to the gastroenterologist stops sulfasalazine and gives mesalamine. Sometimes, they add mesalamine with sulfasalazine. This addition is unnecessary. Sulfasalazine is as effective as mesalamine. There is no proof. Mesalamine is safer, that is true. But in patients who have already tolerated sulfasalazine in course of treatment of IBD associated arthritis, they should be tolerating sulfasalazine for the treatment of IBD also. They are not intolerant. They have already proved that they were not intolerant. So,
Yes, sir.
so actually, I
Yes, sir.
think
Yes, yes.
since
Yes, sir.
actually,
That I do
actually the
agree.
basic discovery of Ajad Khan sir was that, he discovered which moiety is effective for controlling ulcerative colitis. Was it sulfapyridine or 5-aminosalicylate? That was that, and he found out that 5-aminosalicylate was the moiety responsible for controlling ulcerative colitis, not sulfapyridine. But in our case, it is the reverse. In case of inflammatory bowel disease associated arthritis, sulfapyridine moiety is mainly responsible, not the 5-aminosalicylate moiety. So in those cases, we have to, mesalamine is ineffective in IBD associated arthritis. So if a patient has both IBD and IBD, I mean with IBD, I mean ulcerative colitis, because sulfasalazine is effective, much less effective in Crohn's. It works only in milder forms of Crohn's, and also when there is Crohn's colitis. Otherwise, it is not that much effective in Crohn's. So in patients or Crohn's colitis, along with IBD associated arthritis, we must try sulfasalazine. Next question is about the kinase inhibitors. Actually, if sulfasalazine fails, we have to give kinase inhibitor, that is tofacitinib, because we don't have any option. Frankly speaking, our patients cannot afford. As per my estimate, in our country, 500 out of 500 genuine candidates for biologics, only one can afford biologic. That is my observation, and I think Shaheen would also agree with me. From the tone of Shaheen, I smelled this sense of frustration that our patients cannot afford biologics. So we are left with the option of tofacitinib. But one mistake is often committed when initiating tofacitinib or kinase inhibitors in our chronic polyarthritis patient. Even this mistake I have seen in the prescription of our qualified rheumatologists also. Sometimes they don't give the vaccines. Without vaccine, they have started tofacitinib. Sometimes they don't investigate, they don't clinically rule out infection of or neoplasm. That is very important. And also you have to do certain tests, hepatitis B surface antigen, then HCV antibody. If the patient has got rage, I would say ALT, we also need to do anti-HBC total. We have to do that one also. So we have to screen for, viral hepatitis, that is chronic viral hepatitis. We have to exclude. We have to exclude latent tuberculosis and also active tuberculosis. We have to exclude. And I find that, many of our doctors who have taken great pain in passing the MD rheumatology are not practicing this. There is some knowledge practice gap. So I invite all. And, but what Minhaj has pointed out, should we haste with the failure of sulfasalazine to tofacitinib? As Minhaj, I fully agree with Minhaj, we should not haste. We should not hurry. We should try sulfasalazine to the maximum tolerated dose, 3 grams daily. We rheumatologists usually stop at 2 grams or 2.5 grams. We have to increase it to 3 grams. Why? Because, tofacitinib is also associated with intestinal ulcers and intestinal perforation. For intestine, it is not safer. Moreover, there is another point. Sulfasalazine and mesalamine has suppressive property. It is stronger with mesalamine and less strong with sulfasalazine, but sulfasalazine also has got this property. It suppresses development of colorectal cancer in patients with ulcerative colitis. You all know that, colorectal cancers are more common in ulcerative colitis. So, sulfasalazine and mesalamine prevents the development of colorectal cancer in patients with ulcerative colitis. Tofacitinib has, so far, there is no evidence that tofacitinib would prevent development of cancer. Rather, we know that tofacitinib is associated with somewhat increased incidence of cancer. So we should not be hasting to tofacitinib, but judiciously in patients who have failed adequate trial with sulfasalazine, we should switch to tofacitinib. And if tofacitinib fails, then we should switch to, I would say, monoclonal antibody, anti-TNF MMBs, not anti-TNF fusion protein. So these actually, with these words, I conclude my talk. And I thank you all again for your patient hearing. Thank you very much.
And also, you have to conclude the meeting, sir.